Hello, everyone. This is Rafi. I'm here with Dr. Chris Palmer, and he's going to talk to us about what he does at his university, Harvard, and also what he thinks about schizophrenia, mental health, and lots of other things. So thank you, Chris, for being here.
Thank you, Rafi, for inviting me. It's a pleasure to be here.
Awesome. So we met maybe online about 2 years ago now, I would say.
Yeah.
And the sort of overlap we had there was ketogenic diets and psychiatry. I'm a PhD candidate in health sciences, and with specifically a focus on schizophrenia and the metabolic side effects of antipsychotic drugs. And you see patients who are schizophrenics, or I think bipolar as well, and maybe much more actually, as we'll explore. So we had this in common, and you were very helpful in helping me formulate a way to think about these subjects which were quite new to me back then. So thank you for that, and I guess we can start there. So maybe just give a brief background about how you got to these topics in your medical career, and where you think they are leading you down new roads maybe.
Yeah, no, it's a great question, huge topic that I could talk on for hours and hours on end. I'll try to give the quick version. So I'm a psychiatrist. I work at Harvard Medical School, McLean Hospital. I run a continuing ed department. That's kind of my day job. And I have done research for almost 25 years in psychiatry. And I also do clinical practice. I have a small private practice, and I treat a wide variety of patients. The unifying theme among my patients are treatment-resistant disorders. But I see people with chronic depression, with schizophrenia, with bipolar disorder, substance use disorders, personality disorders, the whole kind of gamut. But because I'm in a kind of a tertiary care psychiatry hospital, I almost never get people with like first episode depression or anxiety. They almost always get treatment from their primary care docs or a a neighborhood psychologist, psychiatrist, whatever. I get people after they've been through 5 or 10 of those other treaters and multiple hospitalizations. They've usually tried at least 20 different medicines and sometimes ECT and other things before they get to me. And then they come to me and want me to try to help them. So that's a kind of a whirlwind through my career. And then I've really gotten into the use of low carbohydrate and ketogenic diets in psychiatry really as a treatment. I've been doing that work for well over 15 years, probably going closer to 20 years now. And initially I used it in patients with depression, treatment-resistant depression, anxiety disorders, some personality disorders. And in some of the patients, I saw really impressive results. Some people got dramatically better. And these are people who had tried, some of them 30 medications, plus ECT, plus decades of psychotherapy. Nothing was helping them. And this dietary intervention could help at least some of them. I want to be clear, it didn't help all of them. So not everybody gets better with this diet, but I was seeing pretty significant, profound results in some of my patients. At the time, that was long ago enough, but at the time, the ketogenic diet was still highly, highly controversial. It was basically a taboo topic in the medical field. We didn't have very good research showing that it was even safe or effective for weight loss, let alone diabetes, let alone anything else. And although we had a literature at that point in epilepsy, quite honestly, I really wasn't all that aware of it. I didn't know all of the neuroscience. I didn't know about its extensive use in epilepsy back then, because that is not taught to, it's certainly not taught to psychiatrists or mental health professionals at all. Like just that's across the board. It is not taught to anybody. It is barely taught to most neurologists. Most neurologists in the world do not recommend ketogenic diet as a treatment option for even epilepsy, even though we have a very good evidence base. So back then, highly controversial. I wasn't really willing to publish anything about it. I wasn't talking about it. I wanted to keep my job. So I just kind of laid low and practiced psychiatry and used it every now and then with some patients. And that all changed like 6 years ago, about when I tried to help a patient with long-standing schizophrenia, schizoaffective disorder, try to lose weight. And my initial intention in helping him was really just to help him lose weight. At that time, if anybody had asked me, like, do you think this diet would do anything for schizophrenia? I would have said absolutely not. I would have said schizophrenia is a debilitating, horrible brain disorder. It ruins people's lives. It seems to be a chronic disorder. No one knows what causes it. Nobody knows much about it. Like, really, our treatments suck. The treatments that we have just kind of sedate people, but it keeps them out of prison. It keeps them alive, keeps them out of trouble. So that's maybe better than nothing. But we're certainly not restoring their health. We're not restoring their lives. And a diet to treat that devastating, horrible disorder that is unequivocally a disorder. Like with depression, sometimes people are like wishy-washy about, is it really a disorder? Like I get depressed too. Maybe these people are just wimps. Maybe they just need to suck it up a little more. So with a lot of other psychiatric diagnoses, there's always like this wiggle room or wishy-washiness of like, you know, is it really a disorder? Maybe it's not. Maybe this person's just a wimp. With schizophrenia, schizoaffective disorder, nobody questions that. When you talk to these people and watch them and listen to them, they are quote unquote crazy. They are crazy. They are out of their minds. They believe things that aren't true, that are just wildly ridiculous and not true. They hear things that aren't there. They see things that aren't there. They can become extraordinarily disorganized and unable to function, unable to read, unable to comprehend basic things. There's clearly something wrong with their brains, and almost everybody who knows somebody with schizophrenia knows that. There's no wishy-washiness about it. Mm-hmm. And so anyway, back to the story, I try to help this guy lose weight. Sure enough, he's a trooper. He can do the diet. And it doesn't happen overnight, but within about, 3 weeks, I start noticing dramatic improvement in his mood and his ability to interact with me. He's becoming more conversational. He's making eye contact. He's brightening up. And then it took probably about 2 months, honestly. And about 2 months into it is when he just spontaneously out of the blue starts telling me, those voices that I always hear, they're going away. I'm not really hearing them so much anymore. Like I hear them occasionally, but I can ignore them now. I never used to be able to ignore them. And I think in my mind, much more profoundly at about the 2-month mark, he had these long-standing paranoid delusions. There are conspiracy theories against him. He was the target of these evil people who were torturing him and ruining his life and making everybody think he really had schizophrenia when he really didn't. He wasn't crazy. This was all really happening, but nobody would believe him. And they set him up. They were framing him. He doesn't know why. But, and all of those paranoid delusions started going away too. And he actually got to the point where he said, you know what? Now that I think about all of that, it sounds crazy. And I actually think it's probably not true. Like, I think maybe I've had schizophrenia all along. Like wow. Those things weren't really happening. And So that man went on to lose 150 pounds. He's still on the ketogenic diet today. He has kept that weight off. He went on to be able to, he got better enough that he was able to move out of his father's home for a period of time. Unfortunately, he's back with his father for lots of reasons that I won't digress into all of that, but he was able to complete a certificate program, and most importantly, he was able to like perform improv in front of a live audience, which this man had trouble going out in public. He couldn't ride on a public bus without being terrified that the people on the bus were torturing him, were reading his mind, were there to harm him. And he was thinking that like they probably have a knife in their pocket. They're probably ready to stab me any minute. And so he's on a bus with this experience. Like that was his life, is going around in fear, tortured, that people were trying to harm him, people were conspiring against him. And all of that went away. And he was actually able to get up in front of a live audience and perform. And that ended up leading me down this rabbit hole that has become my new career and passion, which ultimately was not, I quickly went to, oh, I've got to start using this in lots more people. And I've done that now. I've used it in lots of people. I've published lots of case reports. I've published, review articles outlining the science of why this might work, how this might work. But I've actually been much, much more focused on understanding the how and why. And more importantly, what can that tell us about mental illness in general? Like, what can we learn from this? Because this is a very novel piece of research information.
Mm-hmm.
It is highly unusual that a dietary intervention could profoundly affect the course of a horrible, debilitating, chronic psychiatric disorder. And in my mind, it provided a really important piece of evidence to help us better understand ultimately what causes mental illness. And that is really the path that I've been on.
Right. No, that's an amazing story, and it reminds me of actually an anecdote that a friend told me recently with regards to her experience with a person she was involved with who had schizophrenia, and she was telling me about this sensation that her partner had, that she was actually trying to harm him. And this is, very disturbing to the normal person, because it's such an improbable feeling to get back. But in schizophrenia, you do get that. Even it's not just with strangers; it's also with people that are very close to you. And it's sort of shocking. So, like you say, there's no gray area there. When someone is schizophrenic, it's usually pretty clear in that regard, and it's so debilitating, because we don't have treatments. It's not just dietary intervention. The fact that a dietary intervention worked for this person is amazing, but if any intervention worked, that would be amazing as well, because the drugs we have, like you said, are quite ineffective and blunting. And it became clear to me when I started looking into this in terms of remission rates and things like that. It is a bleak view in that sense. So anything we have, even if it is a series of anecdotes, those are still very powerful, because of the effect size, in essence, that they're showing us, that you can really just improve your life vastly after this serious brain disorder. So I guess I'll just ask the question that my friend had is, if someone starts blocking you and doesn't want to talk to you and thinks that you want to harm them, is this, how normal is this? And can you expect this to go and come, or is this a chronic state that you have to expect if you're involved with someone with a schizophrenia?
It's a really good question, and there's a high degree of variability for different patients, for different people. And so for some people, it's absolutely a chronic disorder, and their paranoid delusion against a specific person can be persistent and can last for decades. I've seen that myself. I've experienced it firsthand with family members or friends who've had psychotic disorders. And it can ruin relationships permanently. People can, disown family members because of a paranoid delusion and never really reconnect with them. For other people, the symptoms come and go. They can have good periods and bad periods. And in some cases, the good periods can also, include remission, or at least a waning of the paranoid delusions, to where a person kind of, can kind of, reconnect with people, feel like, oh, maybe they were out to get me, last month, but maybe that's changed now. I'm not as paranoid about them anymore. The challenge is that, although people have these paranoid or delusional experiences or even hallucinations, one of the challenges is that people remember it. And so if you have schizophrenia and you go through, even if it's just a 1 hour episode, if for 1 hour you truly think somebody is trying to kill you, that they really have a knife, you see expressions on their face and you're convinced that they are looking at you with an evil look, that they are really about to grab a knife and put it in your chest, it's hard to forget that experience. Even if an hour later or 2 hours later, that whatever was causing that paranoia is gone, it's kind of come and gone, people's memory still works. And they still remember, oh, you were about to stab me an hour ago. And it's very rare, it's not impossible, but it's very rare for people with schizophrenia to gain complete insight that, oh, that was just a figment of my imagination. That was just an improper brain function. That was something going on with my brain. That didn't really happen. He wasn't really going to stab me. It's very rare that people have those types of insights, especially quickly after such an episode. And for some people, they almost never get that kind of insight. The best you can hope for with a lot of people is that they think, well, no, you were really going to kill me. I know it. But now things have changed for some reason. I see that you're a good person now. Maybe the conspiracy theory people who are involved in all of that, maybe they told you to back off and be nice to me now. So I think you're nice to me now. And so they can get to a point of repaired relationships, but they often are still, they still wonder about it, suspect it, or firmly believe it. And, I just want to say, it is horribly frustrating for people like your friend. So if you are the recipient of this kind of paranoia, it's frustrating, it's heartbreaking, you can get angry, you can get really upset, you can get defensive. But I just want to also put in the obvious plug for people who don't get it. For the person who's going through that, it is a living hell. It is a living hell. to think that people are conspiring against you and about to kill you, or that they are backstabbing you all the time, or whatever. It really is torture for them. And I would love to be able to help those people.
Yeah, I think you described that so well. The more you have an opportunity to get, to lessen the degrees of separation between your experience with those people, it's at that point that you can start to understand that it's a, I would say it's a vast brain disorder, because it's changing so many aspects of the person's experience. And of course, we have such a poor theory of consciousness in the first place that we have difficulty even framing how to intervene into that landscape. But there's something to do with the metabolic state, that is ketosis, that seems to be hitting on so many of the things that need to get right once again. And I have a suspicion that it has something to do with the global redox state of the brain, which, if people don't know, you can imagine the redox state as the charge of a battery. And that is, in essence, the redox state of your brain is, in essence, something that determines its correct metabolic function at the most basic level, at the level of ATP production, and at the level of the basic neuronal firing, electrolyte balance, everything, the most basic stuff. So that is a global brain change that happens from fasting, the ketogenic diet, even the supplementation of ketones can change the redox state. And it's so, because it changes so much, we have it even, we have difficulty understanding how it does it, because so many things are changing. There's so many variables involved. So that is my suspicion. What is your suspicion that might be happening at the maybe more mechanistic level with the ketogenic state and changes in the brain of schizophrenics? And it doesn't even have to be the brain; it could be peripheral. But I'm curious what you think.
Yeah, no, so I will admit that I'm not going to tell you everything I know right now, because I'm working on a book, and
Perfect.
it is making its way that I think I'm hoping that it may make a significant contribution to the mental health field. I'll just leave it at that. The easy answer, the quick answer, for anybody who's followed my work or looks at my website, I pretty much give it away. In the way that you say it's the redox state, I completely agree. It is the redox state. I would, at least in lay terms, I would broaden that just a little bit, and I use the word metabolism. Mm-hmm. And I think that schizophrenia is probably a metabolic disorder of the brain, or a metabolic disorder that is affecting the brain. And we actually, for anybody who kind of hears that and is not familiar with it, or is like skeptical of it, or think, that sounds a little crazy, but we have decades of evidence for this. This is not a new concept. I am not the first person to say this. We have research dating back to the 1960s and 70s, showing metabolic abnormalities in the brains of people with chronic psychiatric disorder, including schizophrenia. What does that mean? Well, in order to understand really what that means, you have to understand metabolism. And most people think of metabolism as burning calories or burning fat. That is one tiny part of what metabolism is. Metabolism, in a nutshell, is the study of biological life. If you understand life and how it works and what supports it and what causes its demise, then you understand metabolism. And it is nothing less than all of that. For a lot of people, it quickly gets extraordinarily complicated, extraordinarily fast. And So, but I'll leave it at that. It's related to metabolism. In terms of why the ketogenic diet might work for something like schizophrenia, the much lower hanging fruit that's pretty accessible to most people is the fact that this is an evidence-based treatment for epilepsy. And it's been used in the treatment of epilepsy for 100 years. We've at least have publications for the last 100 years to this year. We have a tremendous amount of neuroscience on how this diet stops seizures. They relate to, the ketogenic diet changes neurotransmitter systems, which have also, in addition to being implicated in epilepsy, those same neurotransmitters have been implicated in being imbalanced or dysfunctional in schizophrenia and bipolar disorder and lots of other psychiatric diagnoses. But this diet decreases levels of inflammation. There's strong literature suggesting that people with psychiatric disorders have higher levels of inflammation. This diet changes the gut microbiome. There's strong evidence that the gut microbiome might play a role in causing or contributing to schizophrenia and lots of other psychiatric diagnoses. Insulin resistance is a really huge one. There are researchers at my institution, McLean Hospital, that have been looking at the role of insulin in the brain and its role in causing schizophrenia. That's been fairly well articulated already in Alzheimer's disease. It seems to play a role in schizophrenia as well. For those not in the know, again, these all sound kind of cutting edge, or a lot of people are like, oh, this is like, I've never even heard of this. Well, if you're familiar with the history of psychiatry, this actually, we're just digging up old stuff that people discovered 100 years ago. And we're reinventing it and reusing it. But fasting has been fasting has been a treatment for mental disorders since writing has existed. So for at least 2,000 years, we have evidence that people use fasting as a treatment for mental illness. In the 1930s to 1960s, there was this treatment called insulin coma therapy, which was actually the most predominant biological treatment in psychiatry throughout the Western world. So that includes the United States, Europe, and other Western countries. And what they would do is they would give people massive doses of insulin and actually put them into a coma. And they would do multiple treatments, usually like 2 or 3 treatments a week. And they would keep giving you treatments. And the reports were actually that people got dramatically better. Some people were quote unquote cured by insulin coma therapy. I actually had the privilege before he passed away of knowing the former director who worked on National Institute of Health, and even before we had the National Institute of Mental Health. And he was the lead kind of researcher in the United States on insulin coma therapy. And until the day he died, he was actually working on resurrecting it because he said, it really worked. Like, I saw it work, and our treatments today suck. like, we need to bring it back. Now, I'm a much bigger fan of, well, maybe the ketogenic diet is a more humane way to deliver the same mechanisms of action of insulin coma therapy. But so I'll stop there. Lots of mechanisms of action are already well known. Like, even though this sounds new and cutting edge, we have a wealth of existing scientific evidence and clinical evidence in epilepsy to fall back on. And I haven't said this yet, but for those who don't know, we use epilepsy treatments like candy every single day in tens of millions of people around the world for psychiatric disorders. You ask me exactly which psychiatric disorders do you use these epilepsy treatments for? All of them. Every single psychiatric disorder, we use epilepsy treatments, because epilepsy treatments include things like Depakote, Lamictal, Tegretol, Neurontin or gabapentin, but also all of the famous benzodiazepines, the Valium and Klonopin and Xanax and Ativan and these common household names that everybody knows not as epilepsy treatments. They know these as psychiatric treatments. But they also happen to be anticonvulsants. And so we use anticonvulsant treatments all of the time in a wide variety of psychiatric disorders. For some people, they can be quite effective and powerful treatments. And so it is not at all surprising that the ketogenic diet might also be an effective treatment.
Right. There are so many medications. There are so many medications, and people tend to get put on a merry-go-round. There's, I've looked into the algorithms of prescription and for different diseases, not just psychiatric ones, but they tend to be quite just trial and error essentially, and a bit of tradition mixed in to say we tend to try this one first and that sort of stuff. But there's not even something that's necessarily hyper rational in terms of the order in which people try things. So to have an intervention that can skip that is immensely valuable. What would be your most pressing area of research that you think needs to be addressed to take us a step further towards, first of all, figuring out how well the ketogenic diet works, or just the state of being in ketosis? Alternatively, because there could be many ways to induce it, and that could be an interesting area as well. What would you like to see happen in research at this point? What would be the next steps?
I think probably the most important step right now that I'm actually involved with, which is really amazing, is that we need randomized controlled trials. The reason that I say that is because in order to really change the medical field, you have to have randomized controlled trials showing an effect. That's all you have to show. You don't have to prove the mechanism of action, because for almost all psychiatric drugs, but in fact for a lot of medical treatments, we don't know what the mechanism of action is. All we know is that it works, is that it changes a biomarker, or it changes a symptom, or it changes a health outcome. That's all we know, and that's good enough. That's all we need to know in order to use it in clinical practice. But in order for more psychiatrists and mental health professionals to begin offering this treatment and supervising it, in order to get hospitals to start offering this treatment as part of an inpatient or a residential treatment program, we have to have the kind of tried and true medical evidence that this can be an effective treatment, at least for some people. And that evidence has to come. There's no wiggle room around this. There's no way around it. It has to come from a randomized controlled trial. Preferably lots of randomized controlled trials, preferably large ones, preferably ones over longer periods of time, but we have to start somewhere. And that is beginning to happen. So, in the field of psychiatry overall, we have a couple of randomized controlled trials now of the ketogenic diet in Alzheimer's disease, and I am going to include Alzheimer's disease as a psychiatric diagnosis. Because for those not in the know, everybody with Alzheimer's disease, everybody, like 100%, have psychiatric symptoms. They have anxiety, depression, insomnia, agitation, something. And 50% also have hallucinations and delusions, which are the crazy symptoms that I just described for schizophrenia. So Alzheimer's disease definitely has psychiatric components, but we have randomized controlled trials for that. We just got a really outstanding randomized controlled trial of ketogenic diet for alcohol use disorder from the National Institute of Alcohol Abuse and Alcoholism. And the senior author on that paper was Nora Volkow, who is a world-renowned, highly prestigious researcher. And that study, found that not only did the ketogenic diet help people with detox from alcohol, they required less detox medicine, they had fewer withdrawal symptoms, and they craved alcohol less. But that study also found that there were changes in brain metabolism, there were changes in neuroinflammation, and lots of other biomarkers that were really positive. I am actually working with several research groups around the world now to try to get some controlled trials going for schizophrenia, schizoaffective disorder, bipolar disorder, possibly chronic depression as well. So those are getting started. And I think that in my mind, in terms of a research agenda, that's probably the most important thing. Because the reality is I can't treat everybody, you can't treat everybody. The very few of us who are doing this work cannot treat everybody. I will just say it's heartbreaking for me, but if anybody listening to this is thinking about emailing me and getting me to treat you, the answer is no. I'm just going to tell you now. I've been turning people away for 2 years. I get emails every single day, phone calls, emails from desperate people who want to, who want this treatment. And there's only one of me. I can't treat everybody on the planet. I just can't. And so I am doing my best to try to recruit more clinicians. Like, we need to train the workforce to be able to deliver this treatment. And in order to train the workforce, we need evidence to allow them to do it. And I mean, they're kind of allowed to do it now, but it's an off-label treatment. We use off-label treatments all the time, so that's not a big deal. But I want more people offering this treatment.
Yeah, absolutely. Chris, what would you estimate is the success rate of the ketogenic diet in your practice for serious schizophrenics? What do you have an idea? Have you treated enough of them with it to know? And then a follow up to that would be, what have been the sticking points, the hardest points in doing so?
So let me start with the hardest points first, because that influences the answer to the other question. So the hardest thing is getting people to do the diet and stick with it. And it's hard for a few reasons. So there's no question the ketogenic diet is a highly restrictive diet. It requires a massive change to most people's eating behavior. So a lot of the foods that people are used to eating, they have to give up, they have to get rid of. And that's difficult. It's difficult for people without a mental illness. But for people with a mental illness, their brains are compromised. They can't think straight sometimes. They have trouble planning and organizing and learning new information. So it can be even harder for them. The other challenge is that the ketogenic diet, at least early on, again, it requires a lot of learning. You have to learn new recipes, you have to learn all the rules, you have to learn how to measure your ketones, all of that. So it requires effort, but that requires brain function. It requires that you can be organized, that you can learn new information, that you can spontaneously research recipes, that you can make those recipes, that you can go to a grocery store. It means you have to go out in public with all those dangerous people who are about to stab you with a knife. You have to go into that dangerous grocery store, buy food, and then go home and make a recipe and then eat it, and only eat that stuff and not anything else. And again, because of their brain function problems, that can be a really big uphill battle for a lot of people. And then to throw another wrench in the works is that most people with schizophrenia, schizoaffective disorder, are disabled by their illness. They are impoverished because of their illness. That means they don't have money. And it means that if you're asking them to spend more money on fresh meat or fresh low-carb vegetables or MCT oil or, you know, anything else, all of those things are a lot more expensive than a box of cereal or a box of Pop-Tarts. And unfortunately, financially for some people, it's a big deal. It can be almost impossible for them to do it. So assuming those barriers can be overcome, if a person is actually able to do the diet, I usually tell, especially people with chronic psychotic disorders, I tell them that they have to try it for 3 months before we make a decision. That you have to try it for 3 months in order to see if it's going to work. Sometimes it works much sooner than that, but I tell them 3 months before you make a decision, before we together make a decision about whether this is a worthwhile treatment for you. And the few reasons I say 3 months. So one of the reasons, the biggest reason, is because it really can take that long to work in some people. And, you know, giving it 1 week is not a fair chance. Just like medications don't work overnight, and they don't work in 1 week for most people either. They have to take them for several weeks or even a couple of months. And the ketogenic diet seems to work on a similar time course for people with psychotic disorders. So giving it a fair time. The other reason I say 3 months, though, is because a lot of times if you ask somebody 1 week into the diet, like, can you keep doing this? They'll say no. They'll say, oh my God, this is torture. Oh, I hate this. I want my bread back. I want my Pop-Tarts. I hate this diet. This sucks. If you can get them to be on the diet for 3 months, at the 3-month mark, especially if they are feeling dramatically better, that's when most of them will say, you know, it really was hard initially, but it's not hard anymore. Like, this isn't that difficult. Like, I'm not craving anymore. I don't feel hungry. I have good energy. I've figured out some recipes that I really like. I've figured out some meal plans and snacks that I like, that I enjoy. And it's not as bad as I thought it would be. And that's when we then have the conversation about, have you experienced enough improvement to want to continue on this diet? And is this diet doable now for you? And for a lot of patients, if they make it to 3 months, if it really is working for them, the majority of patients that I work with will say, yes, this is doable. Almost all of them. I always warn patients, I always tell them, you are going to go off this diet. You're going to cheat on this diet. And we need to plan for that, because it can be a disaster. You might get really, really sick right away. And they'll usually tell me, no, I'm not going to cheat. No, I won't do that. I argue with them. I tell them, yes, you will. I don't care what you say. You are going to cheat. I know you are. They'll say, why do you keep saying that? I say, because everybody does. Every single person that I work with will cheat. Why will they cheat? Because if you do this diet for 3 months or 6 months, And if it feels, or 9 months, if it feels like all of your symptoms are completely gone or pretty close to it, you're going to want to rock the boat. You're going to want to test the waters and see, maybe I'm cured. I think I'm cured. I don't think I need this diet anymore. I think I can go off this diet and have my Pop-Tarts and my mental health too. And so I'm going to start eating my Pop-Tarts again and I'll be fine. Sure enough, the symptoms will come back with a vengeance. And then I will have the conversation with them. Gosh, were those Pop-Tarts really all that worth your mental health and your sanity and the torture that you've experienced? And invariably the answer is no, it wasn't worth that. So I will stay away from Pop-Tarts from now on. If people can do the diet, for psychotic disorders, interestingly, I have more success with psychotic disorders than I do with chronic depression. With chronic depression, I've at least 1/3 of the patients that I've treated with chronic depression who have maintained ketosis for at least 2 months have not gotten better. It does not seem to work for their chronic depression for whatever reason. I don't know why, but they have at least some level of ketones. There's always wiggle room. There are always things you can change. Like maybe you need to get rid of artificial sweeteners. Maybe you need to get rid of, seed oils. Maybe you need to get rid of, maybe you need to take a probiotic. Maybe you need, everybody's got ideas about what they're supposed to tweak. I welcome some of those ideas, but when you're actually in the trenches treating real people, like good luck. Good luck. I mean, I have all these people from the peanut gallery or these armchair quarterbacks who are telling me how to play my game. And it's like, well, why don't you play the game and then see how well it works out for you? If you've got such great ideas, go ahead, start treating some people and let's see you get 100% success rate. Nobody's doing that. And so we do our best. I'm hoping that with more research, maybe we will better understand like what are the magic ingredients or what are the magic variables, so maybe we tell everybody you must eliminate seed oils, you must eliminate all artificial sweeteners, you must eliminate this, that. You have to have some fiber for your gut microbiome, or maybe no fiber, maybe everybody's carnivore, like who knows. But with schizophrenia, if people can make it, almost all of them experience at least some improvement, probably at least 80%. I'd say at least 80, 90%. I kind of have to say from my own personal sample, if they make it 3 months in a high level of ketosis, meaning greater than 1.0 beta hydroxybutyrate, 100% so far. That's, I don't, 100% have seen improvement, not cure, not full remission. I'm not saying full remission at all, but they've seen improvement. They almost all across the board experience improvement in mood and energy and cognitive function. And most of them will also experience a reduction in psychotic symptoms. How much of a reduction is highly variable. So for some people, it can be a 50 to 60% reduction in symptoms. For others, it's kind of like a 90, 95% reduction, which I have to say is so heartbreaking because it's kind of like, oh my God, you're so close, you're almost there. Right. And then for others, it's full remission. Their symptoms completely go away. I've published 2 case reports and I know of many others who have had a complete remission of all psychotic symptoms, and they get off all their meds and they are living happily ever after. All of them have had remarkable progress in changing their lives, in being able to do things that they had never been able to do before. So this isn't just a change in psychotic symptoms. This is a change in brain function and a change in a person's life.
Yeah, that's profound. It could be even more effective than for weight loss, maybe. If those remission rates hold up in clinical trials, I mean, it'll overturn so much of what's been done in the field so far. I think it's worth just giving a little bit of context in terms of some stats on how well we manage to treat these conditions usually. There's about, you know, um, there's a problem with antipsychotics that maybe actually you should explain this. In the first few weeks, your risk of suicide can go up with antidepressants. In the first 2 to 3 weeks, the risk goes up, and I've always found this very strange for a condition where you're supposed to treat the depression, which is making you already more suicidal than baseline. So sometimes these drugs have a paradoxical effects. And with antipsychotics, over long-term use, there is some argument that has been made that it can even sensitize you to some psychotic symptoms. So they're quite tricky to use long-term. So I wanted to know what you thought about that, and if you pretty much agree with that general description of those drugs.
I do. So this is a highly controversial field, obviously, and I will be honest with you. In the book that I'm writing, I kind of address some of this as well, and I'll go much deeper into it in the book. But I will just say for now that something that I think hopefully isn't too controversial is that every medication in the medical field, I'm not talking psychiatry now, I'm talking every medication in the entire medical field comes with risk and comes with benefits. And part of the risk is adverse side effects, paradoxical side effects, things that even if it's rare, it can be devastating for the individual. Easiest example is an allergic reaction. If you have an infection with streptococcus in your throat and penicillin will cure you of your strep infection, that's great. That's a wonderful treatment, isn't it? Penicillin for everyone, right? Everybody should take penicillin. Well, hold on. Well, although penicillin it's a magical drug and it cures people of a horrible illness that can actually lead to rheumatic fever, that can lead to death. I mean, that strep infection is not, it's nothing nowadays, but back in the day before we had antibiotics, it killed people and it gave them heart failure and all sorts of things. So penicillin's a magical, wonderful, life-saving drug. I'm not being facetious about that. It really is. If you are allergic to penicillin, you better not take it. Like, you could die. You could die from taking penicillin. So going to psychiatric drugs, the fact that people think it's controversial that maybe some people have adverse side effects to psychiatric drugs is ridiculous. Because tell me any other drug in the entire medical field that doesn't have really bad side effects, at least in some people. And so I think it's clear. The FDA clearly acknowledges this with the suicide risk warning for antidepressants. They also clearly acknowledge this with antipsychotic medications. Antipsychotic medications we know cause weight gain, tremendous weight gain in a lot of people. They cause type 2 diabetes. Within 1 day, antipsychotic medications increase your insulin levels and increase your glucose levels. So we know that over the long run, they cause metabolic disorders, including cardiovascular disease, and they are highly associated with premature mortality. Especially, and this is particularly evident in old people, but we know that people with schizophrenia who take antipsychotics long-term they die premature deaths on average. And the amount of years that they lose can range anywhere from like 10 to 30 years, depending on the study you look at. They lose a lot of years of life. And there's almost no doubt that antipsychotic medications play at least a role in that. It's not the only explanation, and I actually don't believe it is the entire explanation. I really believe it's much more about the metabolic problems in their entire bodies.
Yeah.
And people with schizophrenia show signs of insulin resistance before we even give them one pill. So it's not just the pills that we're giving, but the pills are definitely contributing to those problems. I think the issue of can psychiatric medications cause psychiatric symptoms? This is where it gets really tricky and highly controversial. But I'll at least just make some uncontroversial observations that lead me to say, absolutely. We know with certainty psychiatric medications can trigger psychiatric symptoms, new or different psychiatric symptoms. So we know with certainty that antidepressants can trigger manic and psychotic episodes in some people. That is really not controversial. It's pretty well established in the medical field. If you have somebody with bipolar disorder, you shouldn't be prescribing antidepressants unless they are on a mood stabilizer. A lot of experts think that you shouldn't be prescribing antidepressants at all because they might be triggering mood instability, manic episodes, psychotic symptoms. So we know that's a clear case. Antidepressants leading to suicidality, we've mentioned. Antidepressants can lead to new anxiety symptoms. That's very common early on in the treatment. Antipsychotic medications can cause depressive symptoms. The controversy is, can antipsychotics actually cause psychosis? Highly controversial. I won't go there right now, but because I think it's fair enough to just stop there. That's more than enough. So, the overarching rule is, can psychiatric medications have adverse effects? Not only physical adverse effects, but also mental adverse effects? Absolutely. No question about it. Incontrovertible. I didn't mention stimulants. Stimulants can cause psychosis and mania. Most of our animal models of mania and bipolar disorder are actually based on using high doses of Adderall in rats. We give the rats high doses of Adderall. That's a treatment for ADHD. We give them high doses of Adderall, and guess what? They get psychotic and manic. And so, so can Adderall cause psychosis? Well, in rats, we think it can. We have a lot of reason to believe it happens in some humans.
Some college students, definitely.
Yeah, no. So, of course, psychiatric medications can cause psychiatric symptoms. Again, I think the reason these things are so controversial is because people want black and white answers. And so if I say what I just said, that psychiatric medications can sometimes cause adverse effects, people want a black and white. Well, then let's never use them. They're toxins, they're evil, they're just, the pharmaceutical companies are poisoning us, they're just trying to make money, and let's stop using them altogether. Well, that's one approach, but let me come back to penicillin. If you have a strep infection and you are deathly allergic to penicillin, by no means, you need something different. You better not take penicillin. Does that mean nobody in the world should ever use penicillin? Absolutely not. I didn't say that. So just because I'm saying that a medication can have an adverse effect, and even a really serious, life-threatening adverse effect in some people, doesn't mean I'm saying that we should never use that medication. But it means that we need to be smart about it. It means that we need to be aware of these possible adverse effects. And we need to do our best to optimize people's health. And sometimes that means medication. Sometimes it means no medication. Sometimes it means let's take them off this medication, even if it's going to be challenging to get them off of it. So I think there are lots of different scenarios that we need to really take seriously. But all too often, people are looking for really easy soundbite answers. give me a soundbite answer, yes or no, medications or no. It's like, well, you're not going to get that from me, unfortunately, because practicing medicine and treating people, real people, is a lot more complicated than that.
Yeah, and a lot of the research that you covered there was sort of put together by Dr. Hengartner, who people can find on Twitter, and he goes over a lot of this data on antidepressants and antipsychotics with regards to suicide risk and sensitization in psychosis, and also the effect sizes between the placebos and those medications, especially for depression, and how effective they are. So if people want to dive deeper into that, they can look up Dr. Hengartner. I wanted to ask you as well about nicotine and cannabis in the context of schizophrenia. So with nicotine, it's kind of interesting because a lot of schizophrenics smoke cigarettes. So one reason that's given is because of the effects of nicotine have on their mind, and maybe you'll be able to give us a bit more detail there. And then with cannabis, so there's what most people know, the idea is that there's this correlation between cannabis use and schizophrenics, and the cannabis, because it's a psychotropic, can trigger people with an underlying predisposition to it, and so hence you should avoid cannabis. But I've also heard that some schizophrenics say that they smoke cannabis because it can have a quieting effect of the voices in their head, or at least allow them to be distracted by them, because cannabis can have this effect where you sort of jump from one thought to another, and you can get a bit distracted with things happening around you or even in you. And so I heard this from some schizophrenics. So there seems to be this interesting question: would it be a short-term benefit for long-term harm, or is this something that some have used cannabis to cope with productively, or in your opinion is this just an absolutely terrible idea, stay away from it, no holds barred? So yeah, I present you those two things. I'd be really curious to know what you think.
So yeah, I could give entire lectures on either one. But nicotine, I'll just make the obvious point. You are absolutely correct. The majority, like the overwhelming majority of people with schizophrenia smoke cigarettes. They were not smokers before they got schizophrenia. They became smokers after they developed schizophrenia. It does not, now smoking rates are higher in all people with all psychiatric disorders. So I should make that point as well. People with chronic depression are more likely to smoke. People with PTSD are more likely to. People with all mental disorders are more likely to smoke cigarettes. But in the case of schizophrenia, the rates are dramatically higher than for most other disorders. Like depends on what survey you look at least 70–80% of people with schizophrenia smoke cigarettes. It's not entirely clear why. The most obvious reason that I think a lot of people talk about, that I tend to think is probably the truth, is that nicotine is a stimulating medication. It works in a wide variety of brain regions to make those brain regions more active, to wake them up, to get them going. And people with schizophrenia are, by and large, taking antipsychotic medications, which profoundly slow brain function across the board. And that's great for the psychotic symptoms. You want to slow those symptoms, and you want to try to stop those symptoms. So I think that's why antipsychotics can be helpful for psychotic symptoms, is because it's slowing the brain function overall. The challenge is that if you want to be able to think, you want to be able to plan, you want to be able to go to the grocery store and buy keto foods and figure out how to make recipe, if you want to do any of that, you got to be able to have those brain functions work. And nicotine can help wake those up. For a lot of people, nicotine does not seem to exacerbate the psychotic symptoms. So it seems like it's a good treatment, and that's why so many people tend toward it. Because if it was exacerbating the psychotic symptoms, a lot of people would be afraid of it. Like that they would, on balance, they would say, I'm not going to smoke those cigarettes. They always make my voices worse. And the voices are mean to me, so I don't want to smoke. But it doesn't seem to be the case. It seems like nicotine can wake up or activate brain regions that are beneficial and helping people get through life. And so who can blame people with schizophrenia for looking for something that works? When it comes to cannabis, there was a recent review in JAMA Psychiatry in the past like 6 months that really did a comprehensive review of this topic. And so part of the controversy with cannabis is, so I'll at least say one fact. The fact is that people who use a lot of cannabis are much, much more likely to develop a psychotic disorder. If you're using a lot of cannabis at a young age in particular, your risk is even higher. So if you look at 12-year-olds, say, who use a lot of cannabis, this is irrefutable. This is not controversial. 12-year-olds who use a lot of cannabis are much more likely to develop a psychotic disorder by the time they are 25. That is non-controversial. It's just not. If you believe in science, if you believe in research, you have to accept that that is the fact. We've got numerous studies showing that. The controversy is this. Controversy is, well, does that mean that cannabis use is causing schizophrenia or a psychotic disorder? Or the other possibility is, does that mean that people who are about to develop a psychotic disorder are more likely to use cannabis, maybe because it's beneficial in some way? And that question is what these researchers looked at, is trying to tease those two things apart. The third option they looked at is, are they completely just unrelated? Is it just pure coincidence that people who use a lot of cannabis just happen to develop psychotic disorders and they're completely unrelated? They ruled that out pretty clearly. There's no way it's just random chance. The evidence is overwhelmingly clear that there's something going on. The researchers couldn't distinguish the other two possibilities, though. It seems that there is some truth in both of them based on all of the evidence that we have. So it seems that for people who might be inclined to develop a psychotic disorder, they may in fact be people who have ADHD at a younger age. We have evidence for that. The ADHD is associated with a much higher likelihood of developing psychosis later in life. That might be because of the treatments that they're getting. It might just be because of something about ADHD and the brain function, and it leads to psychotic symptoms in some people. It might be anxiety symptoms that usually people don't just develop schizophrenia completely out of the blue. Sometimes that does happen, but more often than not, if you actually, after the fact, if you talk to people, you talk to friends, talk to family members, like, what was the person like 2 years before this diagnosis? Everybody starts coming out of the woodwork saying, yeah, we knew something was off. Yeah, no, he wasn't normal anymore. He used to be normal, but probably 3 years ago or something changed. Something changed in him. He started isolating more. He didn't hang out with his friends at all. His grades started sliding. He was smoking pot a lot. And that is the question. Is the pot smoking causing those symptoms, or is he smoking pot because he's developing these other symptoms, and the pot is somehow calming his brain or calming his anxiety, or if nothing else, putting him in a different reality? Because sometimes substance use, like cannabis, even if it doesn't treat the symptoms, sometimes it just changes your reality and turns an unpleasant situation into a different situation. Even, I'm not even going to say unpleasant to pleasant. It doesn't even have to be that. It can just be, if I'm being tortured right now by some symptoms and I can take something that's going to change that, I might be inclined to take it. Like just make my reality change. Make this experience stop. I want something different. I can't take it anymore. And for a lot of people, that's what substance use is about, is, you know, sometimes substances make people feel great or chill or whatever, but other times substances just make people feel different and help them escape their current reality, which is not very pleasant. I think the issue with cannabis, there's no question that THC in particular can cause psychotic symptoms for some people. So I've seen that firsthand with a lot of my patients. Interestingly, more so with patients with bipolar disorder. Patients with bipolar disorder who are really stable. I've had lots of patients who use all sorts of drugs, and they can get away with using all sorts of drugs. They can use cocaine, they can use amphetamines, they can use opioids, and they get pretty much what you would expect from those drugs, and it's a pleasant enough experience for them, and they're good with it. They smoke marijuana and they get crazy as hell. And so for a lot of them, after years of experimenting with different things, those patients and I have come to the conclusion, like, you have to stay away from marijuana. Like it's a toxin for you. And again, I use that kind of analogy of, you know, just like I did with penicillin. It's like, I know all your friends can use it and it's all good for them. That doesn't mean it's good for you. Maybe it's like you're allergic to it. If that helps you think about it like that. Like, you're allergic to marijuana and you should not be using it, because every time you use it, you get crazy. And but I think the big hit on the block in the cannabis field is CBD, cannabidiol, and that doesn't have so much THC. It depends on what preparation you're getting, but it doesn't have so much THC, and that tends to have more calming effects. And it is being researched for anxiety disorders, and some people are even looking at it as a treatment for schizophrenia to possibly calm psychotic symptoms, or at least decrease anxiety from psychotic symptoms. And so, when it comes to cannabis, it really depends on what people are using. There's so many strains, so many different preparations. You can eat it, you can drink it, you can smoke it, you can vape it, you can do every. They've even got cannabis suppositories. So you can pretty much put it in any orifice of your body.
Cannabis spray.
Yeah. So you can get it in anyway. You can rub it on your skin, and so with CBD, those CBD tinctures and oils and stuff. So lots of ways to administer it. Lots of different ingredients in cannabis preparations. So I think we definitely need more research to better understand, like, are some of them safer than others? Are some of them, in fact, useful treatments? Are some of them causing schizophrenia? All of those are outstanding questions right now.
Yeah, and personally, I'm a big fan of Dr. Carl Hart's view on drugs in psychiatry, where we really want people to have better experiences, and we have to be willing to personalize a lot of these compounds. So you can separate THC and CBD and expect very different outcomes. And it was really interesting to hear you say this distinction you're drawing between bipolar and schizophrenia in the use of THC containing cannabis. So that's really interesting as well. And it might surprise a lot of people that a lot of the other drugs actually can be handled by someone with bipolar or schizophrenia, maybe more in a way that can be managed better. So there's a wide spectrum there, and we have to get better at understanding how these drugs do what they do. But there are just so many of them. It's hard to characterize them in that sense, because the symptoms in these mental disorders are so varied as well. You have positive and negative symptoms, and because they're experiential, they're also, well, there's a whole other realm of variety of how they manifest in people's lives. So they're particularly interesting and particularly hard to treat for the same reason. So, once again, when we get a tool that seems to hit a lot of nails at once, that's why we're super excited. And just to comment a last thing before we close out on the social aspect, because you mentioned, changes to the social lives of people with schizophrenia. So isolation is particularly harmful to human beings, or more specifically, maybe the feelings of loneliness, of being separate from your tribe or your group or your loved ones. This sensation is very powerful, and it in theory motivates us evolutionarily to seek other humans, because it increases our odds of survival at a very simple level. And in my PhD and the experiments I did with my rats, one of the dimensions I was looking at was the social novelty aspect of how these antipsychotics affected these rats that were made to model schizophrenia. And the idea here is to see, how do they spend more time with strangers, or do they spend more time with litter mates? How many times do they sniff? How much time do they spend around them? And so it's very interesting to hear you describe, the sort of the social behaviors of humans, and how it changes. A few months before, a few years before, I started to see he wasn't hanging out with people as much, or he got more introverted, or something like that. And I think people would do well to have an idea of how important this is. And we've had, I guess, the sad demonstration this past year and a half with COVID and lockdowns, that social isolation has such a massive impact on people's mental health. So I guess I'd love for you to have the last word on that subject, because I know it's something that you think is pretty important public health wise as well. So if we close the loop on a better diet, and then maybe better social system, shall we say, what could we see happen for psychiatry?
Yeah, it's a huge topic. There's no question that what's happened over the past year and a half has made clear for anybody who doubted everything that you just said in terms of human connection, and its impact on not just mental health but physical health. The mental health rates right now, we've never in history documented this high of prevalence rates of mental disorders in the population. It doesn't mean that they haven't existed before. It just means we didn't measure them, like during World War II, for instance. We didn't measure them during the 1918 Spanish flu pandemic. So we don't know what life was like for those people. I mentioned those two events because those and many others, I can't imagine that the rates weren't comparable, if not even more, than what we're seeing today. So by no means do I think what we've gone through in the last year and a half is the most devastating human experience ever. It's not. I can tell you right now, it's not. World War II was much, much more devastating than this. People had to make tremendous sacrifice. People were being slaughtered. Everybody was losing loved ones and friends to war. That was a lot worse than what we've been going through. But Nonetheless, in our lifetime, or at least in this generation, this is our crisis. This is our crisis. 40 to 50% of Americans, we have the best surveys probably in the United States, but 40 to 50% of people currently meet criteria for depression, anxiety, PTSD, substance use disorder. Those are usually the lifetime prevalence rates. And right now they have become the 1-year incidence rates. And so it's
Wow.
shocking. The bigger challenge is that, even though things are going back to normal now, and, vaccines are rolling out, restrictions are being lifted, industries are opening up again, restaurants are opening, hotels are opening, travel is starting to be allowed, so people are getting their jobs back and everything. A lot of people think, well, now that things are going back to normal, everybody will be fine. Let me be clear as a psychiatrist, everybody will not be fine. I wish it was that simple, but once these disorders get started, once somebody develops depression or anxiety disorder or post-traumatic stress disorder or alcoholism, it doesn't just go away because the initial event that incited it goes away. They take on a life of their own. The disorders take on a life of their own. And so allowing them to go to parties and hug people, or allowing them to get back to work, that it might fix the problem for a lot of people, thank God. And thank God it will be that easy for those people, but it won't fix the problem for everyone. We're going to have a lot of people, a whole generation of people who are debilitated for at least another year or two, or maybe even longer, because of what started during this pandemic. And it's interesting because this is actually a really important topic to me, which is this intersection. Again, a lot of people look for simple explanations and simple solutions, and they hear, oh, I'm doing work on the keto diet. Oh, I talked to somebody who feels so much better on the keto diet. So there, problem solved. Everybody go on a keto diet and the world will be happy, and all health problems will be gone. We're going to stamp out mental illness and cancer and heart disease and diabetes and obesity, and everything's going to be fine if everybody would just eat a keto diet. I can't tell you how much I wish life was that simple and the world was, and human biology was that. It's not that simple. I can tell you that now. It is not that simple. And so in addition to biological interventions, whether they be diet, whether they be pills, whether they be, exercise, other things, we do have to think about psychological and social interventions and constructs, because as you said, we are hardwired for being in groups of people. And it's so fascinating to me because there's like risk and reward in that. So human beings are hardwired to be with other people. And so therefore, if we are with other people, that should be a good thing, right? Well, on one hand, it is, and it is an essential thing, actually. It's almost like water or oxygen. We need it. We must have it. If somebody put you on a desert island all by yourself, you would start feeling distressed pretty quickly. It would suck. But the other challenge in being with other people is that other people are the biggest source of stress to all of us, because other people can be cruel and vicious, and they want to be right. They don't want you to be right. They don't want you to have the better job. They want to have the better job. They want to feel smarter than you. They want to be better looking than you. They want to get the better mates than, from you. They want to get the better grade in the class. They don't want you to get the top grade. They want to get the top grade. And so human beings get horribly competitive and hierarchical. and this permeates life on Earth for the human animal. And so we're stuck with being with other people, and yet other people torment us. And it's kind of the way I look at it. And
Very true.
and it's difficult to it's difficult as I ponder things like this. I know what the right answer is. The right answer are these lessons that we teach little 4 and 5-year-olds. Be nice to each other. Like, genuinely be kind. If you don't have something nice to say, then don't say anything at all. Keep it to yourself. It's interesting, though, that we teach these lessons to small children, and we expect them to try their best to implement them. But then when we become adults, we forget all about them, and we become ruthless and cutthroat. We get more sophisticated at hiding it, or unleashing our anger or hostility or competitiveness or pettiness onto others. But you know, I think the answer lies in a utopia where everybody's nice to each other and kind to each other and respectful. Doesn't mean that everybody's equal. We're never going to all be equal. We all have our strengths and weaknesses. People have disabilities. Some people are gifted. It's always going to be that way. But can we be respectful of everybody in spite of those differences? That's the part. It feels like it should be possible. You know, lots of religions, lots of political systems are set up under that premise, that we should all be able to be kind to each other and respect each other, and that people should be given equal access and equal opportunity. Yet we don't really actually do a very good job of implementing it.
We don't, but there's hope on the horizon. We're now in, I think, phase 2, approaching phase 3 trials for MDMA in the United States, where it might have an emergency authorization act. And this was first used as a couples therapy tool when it was first discovered. So, you know, maybe we'll have a little bit of chemical help to be a bit kinder to each other and compassionate. And as for the existential aspect, or even the depression aspect, where there's also, I think it was in JAMA, that the new psilocybin, so magic mushrooms active compound, psilocin and psilocybin, tested against escitalopram, the antidepressant, head to head. And some very interesting results to dig in there. So for people who are desperate, don't give up. There are many things you can try, and remain open-minded to what those, you know, could be, whether it's a diet, a drug, or even breath work and your circle of friends. You could be very surprised by what works for you. So if anything, just keep trying. And yeah, thank you, Chris, for taking the time to speak with me. It's an absolute pleasure. I could do this for hours, and I hope we get to do it again sometime this year, and definitely when you have your book out. So remind everyone about your book and any upcoming plans you want to mention, and where they can find you on Twitter and elsewhere.
Yeah, no, if people are interested, probably the easiest place to find me is my website, chrispalmermd.com. So I have different articles that I published both in academic journals, but also in like Psychology Today and blog articles and stuff. And if you want to follow me on any social media, you can figure me out from there. You can follow me right from the website. So that's probably the best place to check things out. I'm pretty active on Twitter. I'm not as active on other social media platforms. But Yeah, no, thank you so much. And I do want to say, even though I ended on such a pessimistic note, thank you for changing the tune. Because as a rule of thumb, I'm a very optimistic person, and I really do
Definitely.
believe there is hope for everyone, and everybody's lives can get better. I guess I just get a little sad that it feels like we could all be so much happier and more productive and less stressed as a species if we all did a better job of getting along with each other. So maybe everybody should use MDMA to make that happen.
Hey, there are worse things you could do, I think. Certainly. All right. Well, thank you everyone for listening, and I'll catch you soon.
Thanks.
Bye.